amount here. It's very easy to open up the fascia. Do not do that. Otherwise, the child will have a lot of pain. All right. All right. Now let's see what is pending. Can you pour some saline?
We welcome Professor Subhan Saab.
Now, sir, is it likely to have recurrence in this patient requiring a second surgery?
Unlikely?
To have a recurrence requiring a second surgery in this patient?
Unlikely.
Absolutely unlikely, because I have gone till the boundary.
It will not be that significant to close the coni.
Correct.
So even the adults are with residual adenoids.
Yeah. So this was all the bleeding which was after debridement.
Yes.
Can you pour some more saline, please? So these are the boundaries of the adenoid on both the sides.
Yes.
Now, any questions on adenoidectomy? You can see the buccopharyngeal fascia, you can see the periosteum below this sphenoid bone.
What about, there is a delegate wants to know the boundaries of your, this adenoid bed.
Yeah, so this is the periosteum below this sphenoid bone,
Sure.
superiorly.
Yes.
Lateral anterior is the torus tuberous.
Sir.
Lateral posterior is the fossa of Rosenmuller.
Sir.
I can see a little bit of tissue which I am coagulating. All right.
Yes.
Just the last layer which I am still coagulating. The posterior boundary was the fossa of Rosenmuller.
Sir.
This is the buccopharyngeal fascia, which is the posterior boundary. There is a very little bit of amount of tissue on top, which you can coagulate and leave. There is no need to remove each and every lymphoid tissue by ablation. I am coagulating it. Can you see that?
Sir.
So you can coagulate very little amount of tissue. Obviously, you should not produce black areas.
This is some bleeding point on the right side.
I am just checking for it. If I find any, this is all the collected one. If I find any, I'll coagulate. I do not see any.
So this patient had a type B tympanogram on the left side. The right was type A.
Correct. So now this should improve by itself.
This will improve. So
yes. See, this is the reason I have removed the tubal tonsils. Can you see that?
No. Do we need to do myringotomy or?
No, sir. No, sir.
So
Not
once
at
you
all.
remove the adenoids, it must resolve.
Absolutely yes. All right, sir. Now let's see the tonsil that we had operated earlier. This was the tonsil fossa. There is no bleeding. This is the intracapsular tonsil fossa.
Sir,
And this is the extracapsular.
Sir, once you are done, you can shift to the other table.
Right.
And go ahead with the dice. Dr. Salman is there. He
Perfect.
will ensure the hemostasis.
Perfect. No, there is no bleeding. We can extubate the patient right away.
Okay.
Thank
Come
you.
on, claps for the surgeon for a beautiful demonstration. Thank you very much.
NMC also has to take a picture.
Makbul. Oh, Riaz. 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 Oh, Riaz.
Bu nasıl karışık? Doğru. Riyaz'ın bir gösterdi. Sana şuna bir numara çekmesin Riyaz'ın. Bir numara çekmesin. Bir dost var. Bir tane bir şey var. Very good. Hello.
Dr. Ankit.
हाँ सर saya bıçız Riyaz.
Kasus table 2 hospitals.
Okay sir.
Can you machine service?
Okay, sir.
Dr. Ankit.
Yedi sir.
There was KS car present table 2 पे ठहरी.
Okay, sir.
Camera है ना table 2 hospital sorry.
Okay sir.
There is का KS
Ashna
presentation
Bhavi
line is.
tour.
Ankit. Ankit, can you hear me? Ankit. Hello. Ankit.
Yes sir. Am I audible sir?
Just be gentle. Don't shout.
Okay sir. Am I audible sir?
Yeah. थोड़ा सा ज्यादा है अब ज्यादा तो सुस्त हो गया.
No sir.
हाँ. ये डॉक्टर विकास किधर है?
Sir he's right here sir. He's right here.
उसी के बाद जहाँ बैठ के उधर ही एक हिस्ट्री पर ताकि उसको भी समझ आए क्या है.
Okay sir.
कैमरा वाले को बोलो उधर दे.
ठीक sir.
कैमरा है ना?
Yes sir. Camera.
डॉक्टर सफर. डॉक्टर सफर. डॉक्टर सफर. Okay, go ahead.
Sir.
ये आपका लैपटॉप नहीं है वो स्लाइड का है. Come show us on the laptop.
Yes sir.
यार इसको बोलो ना ऐसे चला पढ़ो ऐसे.
Okay sir.
पढ़ो. डॉक्टर विकास को साथ में.
Yes sir. So I'm presenting a 30-year male. He's a businessman by occupation. His history is he's snoring from last 3 years. His nighttime symptoms were restlessness and heart palpitations. His daytime symptoms were excessive sleepiness, fatigue, difficulty in concentration, as well as nasal obstruction from last 3 years. His past history is he's hypertensive and he's on medication. His personal history has disturbed sleep. He stopped smoking for 6 to 8 cigarettes per day, and he has normal bowel bladder movement. So his general examination, his weight is 79 kgs, height is 167, BMI is 28.3, he is overweight, and his neck circumference is 41.9 centimeters. His ENT examination, his E examination is normal. Nose examination is crooked nose. His DNS towards right side with caudal septal deviation. His throat examination, his Fedman palatal score 3, tonsil score 3, uvula
Go slow. Go slow.
Okay sir.
Treatment, this palatal score is how much?
So palatal score is 3.
Okay. Tonsil treatment.
3.
Treatment, tonsil score?
3 sir.
3, okay, go ahead.
So his uvula is swollen and ulcerative. Overpharyngeal is overcrowding. His combined Fedman stage is 1 sir.
How was? 3 and 3?
Yes sir.
Not correctly, it's 2. Come on.
Okay sir.
It's 2. Treatment 2.
His facial inflammatory is class 1 with no malocclusion. And sir, his NCCT knows PNS. Sir, he has deviation towards left side along with the concha bullosa of left side, sir. In his sleep study report, says level 3 sleep study report. His Epworth sleepless score is 14. His overall apnea and hypopnea score is 92.2 events per hour. He has totals on his overall sleep period is 2810 snoring events, 81 events of hypopnea, 618 events of obstructive apneas, 47 events of central apneas, 33 events of mixed apneas. A fall of oxygen saturation occurred to the maximum of 62% of during apneas. In his polysomnography, he has severe obstructive sleep apnea of AHI of 92.2 events per hour with desaturation to 62% from baseline of 96%. His diagnosis is DNS with end nasal deviation, tonsil hypertrophic grade 3, floppy bulky soft palate and uvula with OSA.
Can you give this mic to the
Okay, sir.
Hello.
Yes.
Yeah.
Can you now simplify the
Yeah.
these findings and your plan for the surgery?
Yeah, so basically this patient has a very severe obstructive sleep apnea with AHF 92,
Yeah.
most of which are obstructive apneas.
Yeah.
So if he had majorly hypopneas, I would have thought the problem would lie majorly in the nose.
Nose. Yes.
But his problem is majorly apnea.
Yes.
His desaturation is going to, he's getting to 62. So he definitely has a problem with the throat. Now in the throat, as he said, there's Malampatti and Friedman is correct. So
Both three.
palate is 3 and tonsil is 6. So large tonsils and long soft palate, and the tongue is not very large. So we still need to see whether his gloves, nose drop. So what are you giving? Don't give propofol. Dexmedetomidine. Don't give propofol.
We lost the picture. We lost the picture. Okay, sir.
Yeah, so basically we need to see whether his problem is because of the soft palate or base tongue or epiglottis.
Okay.
So therefore we are doing drug-induced sleep endoscopy.
Okay.
Like you had said, madam had said that dexmedetomidine
Yeah.
and propofol were two drugs
Yes.
because his AHI is very high,
Yes.
92. So I would not want him to be, completely knocked out. So I would ask them to give dexmedetomidine. Nose drop, please.
The sir is doing now dice.
Can I have the microscope? Flexible.
After that, yeah. Just monitor how.
Hello.
No, I'll just put this pattern.
Hello, Dr. Ankit.
Doctor,
You are having some photographs.
It's very thick.
Of this patient.
सिर्फ नाक में स्प्रे कर दीजिए, चलिए ड्रॉप डाल सकते थे तो स्प्रे. Sorry brother, sorry.
Dr.
Sorry
Salman,
brother, sorry sir. 2 minutes.
Makbul,
Sorry.
audio visual is intact.
Sad. I cannot see anything. Can you increase the light? हाँ? अभी 1 मिनट तो करना पड़ेगा ना थोड़ा. Sorry? क्या बोल?
Makbul, Sachi, how will monitor? So how monitor? How monitor? Sir, light कितना बंद है? सारी light कितना बंद? Let's take pictures now.
Can you turn the head towards me? Towards me. Very thick scope, na?
क्या लगे? ये तो क्या wish करा? बस हो गया. But this monitor, sir. How much?
बस बस लास्ट
Yes, we can see the palate now. Yes, we can see the lateral collapse. Sure?
So this is the salpingopharyngeal. Can we have silence, madam?
Yeah.
So this is the, you can see a little bit of adenoid, which is not too much, but salpingopharyngeal fold.
What's the hypertrophy?
Yes. Now I am in the,
Lateral collapse. Okay, sure.
all right, sir.
This is a.
Sir, can you see-
Epiglottis, yes, you can see.
Yeah.
See, the tongue base is okay, I think, huh? You have.
Yeah, now we can induce this patient.
Yes, yes, yes.
So these are the tonsils
Yes.
and the posterior tonsillar pillar,
Yes.
which is coming very close.
Yes.
Can you increase the light by any chance? Can you increase the light of the scope? Maximum. Put it to
Kariyo tha,
maximum.
white balance kariyo tha?
Put it to maximum.
Yes, now it's okay.
Yeah, perfect.
Yes, yes. We can see well, sir. You can see the laryngeal inlet. Well, there is no secondary collapse, eh?
So right now the patient is not really completely induced. It will take around 5 minutes. We'll wait for that. So जाओ. Now you see his problem seems to be majorly in the soft palate. But we'll wait for him to start snoring and go into apnea. I want to see at least one apnea. It's the lower part of the soft palate, so it's a great candidate for palatal surgery. No, it's okay. Right now it is 93. His lowest is 62, so don't worry. No, he's still not sleeping. Wait. No, don't wake him up. Don't wake him up. What is the best score? You have put a best monitor. What is the best? Where is this? Put the bit. Put the best. Best चालू करो. बेस आ रहा है नहीं आ रहा? चालू करो. बेस का मतलब है इसको चालू करो. Sensor check. Sir, so can you see?
Lateral collapse, you can appreciate.
Hello.
Sir,
There is no need. Don't disturb. Can you see that the patient is now, he's sleeping now, he's snoring,
Yeah.
but his tongue base is not a problem. Epiglottis is not a problem.
Yes, yes.
Right? So his palate is a problem. So you can see the lower part of the palate. It's majorly lateral collapse, but also AP lateral both. Majorly lateral. Now you can see in apnea. So he is in apnea. His saturation is now going below 90. Right? So this is the best stage to look for the collapse. So even at this stage, Let me try to see, even at this stage, see, now he is into complete apnea, but still his tongue is not collapsing. It's only the soft palate.
Yes, yes.
So I am very sure that he'll do extremely well with palatal surgery alone.
Sir, what about the velum?
Yeah, so this is the whole velum, na? Velum is collapsing, na? Entero-posterior both and lateral both. Lateral is more than AP.
Sir,
Lower part of the velum.
no, that is actually the oropharynx, na?
No.
If we classify it according to the word, where will you put it, sir?
Sir, see, this is the whole velum.
Now, where will you put it in the word? Velum, oropharynx, tongue and epiglottis.
Right. So, one sec, let me show you. Okay, so this is whole is the velum. Velum is the long tube. Oropharynx will be below this. See, this is all velum. Oropharynx is this. Tongue is this. And epiglottis is this.
So, you say this is
See, tonsil is a part of the soft palate, na sir?
Upper part.
Sir, velum is the name for palate. Tonsil is a part of the
Oropharynx.
tonsil is a part of the soft palate. Tonsil is hanging on the soft palate.
that is okay, sir. Actually, my question is very clear. You have to classify it in the word. So where will
Why I have to classify in both? Eric is my friend. Eric Kezirin is a good friend of mine. He gave one classification, I gave another classification. That, sir, what I'm saying is, let's talk about the structure, what we have to operate. Let's not get caught into classification and fight on that. What structure should I operate?
Obviously, the palate.
Absolutely. So tonsil is a part of the soft palate.
That is okay, sir.
Correct. So whatever classification you want to give it, you give. But problem here is that good part is that the tongue and the epiglottis are not collapsing. The whole soft palate is collapsing, both AP and lateral. I'm going to operate on the soft palate.
Point taken, sir. Point taken.
And the lateral pharyngeal wall, the hypopharyngeal wall is also collapsing to some extent.
Yes.
So obviously that will keep on collapsing. That I cannot do surgically.
Yeah, okay.
Right? So there are many NOHL classification. We have given our VSV Indian classification, and therefore in the VSV classification I have given a very gross. Now the saturation is up to 80. So we are going to ventilate and intubate. Standard oral intubation. He also has got a deviated septum. He also needs a septoplasty and turnoplasty. Whether you want to do it in the same stage, from my side you can do it.
Yes, you can do, sir. This
You can do.
turbinate. We want you to do turbinate.
So let's first do the soft palate.
If the palate, then show you this.
Correct.
Formation.
Correct.
You cannot consider utmost part of soft palate. You cannot consider as oropharynx.
क्या है उसके लिए?
Upper part, well. Upper part, this oropharynx is well. Well, is not simple. This is okay. Good carefully to it.
Why shasam?
The velum is not complete.
These are exam.
The velum should follow it.
Exam.
Upper part. Upper part, oropharynx is very well. Larynx, tongue based
Lateral collapse of the tonsils and new tonsils, which is one of the grade 3 tonsils.
Can we have some comments from Musa? Does the new dice?
Oropharynx, traditionally we have been classified. Traditionally we have been classifying dice findings on ward traditionally. There are many classifications that have come out, and for routine teaching and routine examination, we examine oropharynx separately and velum separately.
Yes.
And the soft palate, uvula, anterior fascial pillars, they will be classified separately, and the tonsil size, its medial position, etc. And the lateral pharyngeal bands that we see as the palatopharyngeal band, that is also collapsing in this way. We can get the palatopharyngeal muscle also. So that will open it up. Plus tonsil, plus velar surgery, that will happen.
मेरे पानी की बॉटल थी वो कहाँ है? मेरी बॉटल थी वो एक बंदा था ना जिसके पास मेरा बैग था वो मेरे पानी की बॉटल
जी कोई हमारा इधर है अजी मेरा लंच वंच क्या तो
चाय भी आ
हाँ
चाय भी आ रही लंच भी आ
नहीं आइसक्रीम नहीं आ रही
आइसक्रीम हमारी होगी
आइसक्रीम होगी वो फिर से करती है No, but it's a conference with a difference. No delegate badges. No sponsor other than Citizen Clean. Unfortunately, they don't have a base in Kashmir.
They have first
They ask us to do, then we will do. Whether they will do or not do, that is again a mystery. So no registration fees. So we promise you pretty double. We also saw no mementos, no chairperson. So we are trying to make a point that we can do a workshop without these things also. The payment just pay for the 10,000 for NMC. Good, but if you ask, it's free. How much pocket 5,000? You spend it for the others number it. And you get credit for the certificate. And there are many faculty members, they know how I manage certain things. That will be a secret. She's minute for half minute.
नहीं सर चाय का
You can catch it. Yeah, very funny.
इंतजाम करा
Bu da doping. Şimdi ya ben ya spreyim şuna ya. Ne de şey ne de Şu bağlı ha. Çıkaracak akıl. Çıkartır beni. Çıkartır bırak. Ya kesen bu. Macir. Ya kes kırı bu.
या गेस
I'm not sure. What's going? That's true. It is all I'm not sure. Some 8-9 months before the parliamentary election, I was sitting in a room. Somebody knows I was taking the class. One fat man, OSA guy. He's telling me, he's coming to.
लाइट उसका वीडियो बनाओ लाइट
मैंने आपको बड़ा किसी चीज को मुझे उसको लगा कि सारे कंपनी करें वो दिखता है फिर वो किसी ये मत कर हाँ ये भी करो ये करो तो आप बैठो नीचे आप एक काम करो वो इसीलिए तो स्टूडेंट्स को अच्छा उसका है मुझे नहीं करने सकता Supply के पीछे टेंडर न्यूज़ सही सेकंड है ये हमने पंजाब से लाए सब रिजेक्टेड जब एक वन फिक्सिंग कसर बोर्ड पार्लियामेंट विद द बोर्ड वाइज